I'd like to thank the Surgical Society, Medical Surgical Society for having me here. I'd like to also thank a lot of you in our community who are helping to manage neuro-oncology patients in our community. So again, thank you so much. Is there a clicker? I have no relevant disclosures. To give you a little bit of background on me, I trained here in Utah. I did my residency at the University of Utah and specialize in neuro-oncology and skull base. A lot of the work that I do is on minimally invasive endoscopic skull base, and that's sort of a burgeoning field and a new set of techniques that we're really excited to bring back to Utah and develop to improve outcome for patients and develop in the research lab. So maybe we'll talk a little bit about that here. I want to talk a little bit about some of the emerging surgical technologies in our field, some of the integration with other specialties, including neuro-oncology, as well as some of the changes in how we understand and manage brain tumors and other central nervous system tumors. So to talking about minimally invasive surgery and improving surgery, this has been well known in many types of surgeries. And one of the most common types of malignant brain tumors is in glioblastoma. I'm sure many of you have heard of this type of tumor. It's a primary brain tumor. It is aggressive. Median survival is about 14 months. We can get up to about 2 years survival at the University of Utah with a lot of clinical trials and secondary therapies. But our group, as well as many other groups, have shown that surgery still has an important role to play in survival. And I could have put any kind of brain tumor in for this slide. Basically, surgery has an important role for improving survival for a large variety of patients, large variety of tumors. We did an analysis essentially showing that extensive resection and removing more tumor helps improve survival. But more recently, a lot of literature is looking at quality of life in patients, complication profiles, and whether simply just taking more tumor out is beneficial for patients if you're causing harm. This is a study we did here at the University of Utah showing that in the elderly population, if a surgical or medical complication, sometimes this could be as simple as a UTI or a PE, things that are manageable in an outpatient setting. Any sort of complication does result in a loss of survival. Basically, the surgery that we're doing loses its effect. And you'll sort of see on this slide that the figure C and D, basically looking at these survival curves. Despite doing gross total resection, removing all tumors, in figure D, if you have a patient with a complication, you really drop off your survival curve. And we think the reason for this is that you don't get to adjuvant therapy, chemotherapies and radiation therapies that are really important. And that's what I think a lot of neuro-oncology and oncology in general is moving towards, is the molecular understanding of disease and knowing that adjuvant therapies are really critical to patients and their survival and quality of life. So the role of surgeons now is to maximize quality of life and reduce complication. That's kind of what our goal is. So less is more for us. So how do we do that? What are emerging technologies that we can use to improve minimally invasive surgery and make it safer for patients? So here's a selection of different things that exist that we currently use to various degrees in our operating room. Neuronavigation, which is basically a GPS system for the brain. You can scan a patient's CT scan or MRI into a computer system, use a system in OR to point to where you're at in the brain and be able to tell you in real time where you at on a scan. It really helps improve, reducing the size of your craniotomies, improving resection. You can map functional territories onto the brain, so you can avoid motor strip, you can avoid speech areas. Awake mapping, and also mapping while patients are asleep, using electrical stimulation to identify functional territory, improving integration of functional MRIs and tractography. Basically, there's an emergence of a field in connectomics and neurosurgery and neurology, where we are starting to better understand how these white matter tracts connect the brain and understand that the brain is not just an isolated set of systems, but that there's entire networks that are at play. And when you do surgeries, you have to take into account these networks if you're to achieve better outcomes for patients. And ultrasound I put up there as an emerging real-time way to see what you're dealing with in surgery. Here's a patient where everything kind of integrated together. This is a 34-year-old patient that presented with seizures. It was found to have a right side lesion. We were unclear initially whether this is a motor strip or sensory strip, so she underwent functional MRI to identify that this is premotor, that this was an area outside of the, sorry, not premotor, that it was in the sensory area, that it was outside of area of motor cortex. She underwent awake and asleep mapping to identify functional territory. We resected the tumor successfully while she was awake, and then she underwent intraoperative MRI. One of the great advantages of the University of Utah is we have intraoperative MRIs to do surgeries for various brain tumors where you keep patients asleep, scan them, make sure you've taken out all the tumor, make sure you are trying to get up to a functional area safely, and then postoperatively underwent follow-up with a tumor board and sort of management for all the adjuvant therapies that need to be that need to be done for a patient like this to have the best outcome. So this is sort of integration of all those different surgical nuances with the best postoperative management we can currently. And with intraoperative MRI, it's certainly expanded to other cases. This is a study we published, a multi-center study of 314 pediatric patients who underwent treatment using intraoperative MRI. 47% of patients underwent additional tumor resection after intraoperative MRI use, with over 88% of those samples being positive. Basically meaning you can stop a surgery earlier, you can get a scan, you can see if there's ability to take out more tumor if you can do it safely. So just an example of some surgical intervention. Another exciting and relatively new technology that we have is something called laser interstitial thermal therapy, or LIT. There are two companies that make this, and basically it's a laser electrode that heats up at the tip, and you can control how much therapeutic effect you're getting from that. The real advantage and some of the foundational work that was actually done at the University of Utah now allows for you in an MRI to be able to tell exactly where you're heating up, exactly where you're teaching. You're not just blindly zapping an area and hoping for the best. You can actually physically see in the MRI where that heating is happening. You can control it. You can do test doses where you can test how much of a spread of effect you're going to have and then actually do a treatment. So a lot of interesting applications of this for deep-seated tumors, things that are otherwise going to be more difficult to resect safely. These have been used for temporal resections, hippocampectomies for patients that have seizures. We've done corpus callosum disconnections for patients that have seizures as well. This is an example. We're one of the first centers to publish how you could use these for treatment of cavernous malformations in the brainstem. Previously, people had only talked about how you could use this for supratentorial, basically cortical cavernous malformations, and we showed that in two patients having recurrent bleeds, symptomatic bleeds with brainstem cavernous malformations, that you could actually safely treat these lesions and get long-term control. So again, another example of technology that is changing how we do treatments. My real interest is in endoscopic skull base. This is a patient that I recently treated that the traditional method of treating this kind of patient would have been a large open resection. As you can see kind of on the scans, this patient presented initially with confusion, altered mental status, severe frontal lobe dysfunction. She had a lot of cerebral edema, peritumoral cysts. So I think if you did an open resection on something like this, it's very achievable. It's been done for 50 to 70 years, getting safer and safer. But you are retracting on already compromised brain to be able to do that. So what we did and what we've tried to do is an endoscopic technique. And can I play this video or? There we go. Basically, as you can see, it's a olfactory groove meningioma is sort of what we're dealing with. This was a very large lesion. Sorry, I don't see it playing. Is it okay to play this video? Oh, it was playing? Can we skip forward a little bit? Oh, I guess it's not on my monitor. Basically what you're seeing here in conjunction with our ENT colleagues, endonasally we're going through the nose as we're sort of drilling out bone around the cribriform plate, sort of on both sides lateral to the orbit. Using neuronavigation, you can protect the eye, you can avoid structures of the eye, important structures including the carotid artery, various cranial nerves that are going in the orbit. We're using electrocautery to take the blood supply of the tumor. And what it's very useful for this approach is that the blood supply for this particular tumor comes from underneath. It comes from the ethmoidal arteries. So by taking that out right as you go through the cribriform plate and dura, you're devascularizing the tumor right at the beginning. So again, we're drilling out bone. We can clearly see kind of the borders of what's normal and abnormal bone. We start to dissect the tumor. This is how you take out brain tumors anywhere. You basically try to debulk the center of them. This is an ultrasonic aspirator that we use for the nose. And then this becomes a two-handed microsurgical dissection where you're carefully cutting the tumor away from the brain and protecting it, coagulating any important vessels that you can preserve, cutting away the attachments of the tumor. And in this kind of resection, we were able to get a complete resection around it. All the dura that was involved with the tumor was removed. The bone that was involved with the tumor was removed. You're kind of seeing little by little sort of how this is done. These are tedious, challenging cases. They take a long time. There's a lot of pressure on our OR staff to do these cases, but I think the benefit for the patient has been tremendous. You don't retract the frontal lobe. You don't have to put more pressure on the frontal lobe. In order to fix the defect, you have to fix this in order to prevent CSF leak. So here we're getting hemostasis, and in order to this is the attachment of the falx where the tumor was that we're getting hemostasis as well. In order to fix this, our more current technology allows for multi-layer closure. So we use a piece of fascia lata from this patient's thigh as well as a nasoseptal flap from the nose. So whereas 10, 15 years ago the CSF leaks for this kind of location were 20 to 30%, with the use of vascularized tissue and other surgical methods, we can really cut down the risk to under 10%, 5%, sort of depending on what study you're looking at. So again, I think there are huge roles for endoscopic skull base surgery in reducing the burden on patients. You'll see with follow-up imaging on her that the frontal lobe edema resolved, the cystic portions of the tumor resolved. She's out 6 months now and doing great and sort of back to her daily activities. We don't do this in isolation. There's still a lot of room, a lot of need for continuous work in skull base and neuro-oncology. One of the areas we're we're teaming up with other multidisciplinary centers, other academic centers around the country is shown here. There's an entity called RAPID, which is a multi-center group looking at pituitary surgery and hoping to expand to other skull-based surgery in a way to pool our data together. I think our field is very limited by the small sample sizes, by the heterogeneity of the cases, reliant on expert opinion. And so what we're doing is grouping the best data from experts around the country on skull base and pituitary surgery to try to pull all the best practices together. So this is work, these individuals are from all around the country, and there's a lot more to learn about this. There's so many questions for us. Many times when we're working with these patients and helping answer questions and sending our notes back to you guys and endocrinologists and ophthalmologists, there's still many questions that are unclear about recovery, what activities of daily living are going to look like for these patients, recurrence rates. So there's a lot of room for growth and learning. I wanted to talk a little bit about how does the other sources of understanding these tumors impact our treatment. And we as surgeons hopefully can branch out from being more than just cutters. And I think that the modern day surgeon, I think in every field you can see this as well, is really the integration of better understanding of these diseases in the treatment of patients. So whether it's talking about immunotherapy for the treatment of patients, figuring out which types of neuro-oncology diseases can be treated with immunotherapy, what type of immunotherapy, whether we're looking for targeted treatments in, we talk about targeted therapy for craniopharyngioma, another type of brain tumor where certain subtypes have a specific mutation that you can target with a treatment that's not a chemotherapy. that's currently in clinical trials here at the University of Utah and at other places around the country, and other things such as better understanding the molecular biology of tumors. So we put an example of how we use pituitary tumors. Instead of just looking at histological markers, now we really do rely on the mutations of these tumors to understand what kind of tumor they are, and then we can offer counsel for patients to say this is a likelihood of recurrence, this is a likelihood of a surgical remission. Really, for pituitary tumors as a great example, the use of genomics in understanding them has been critical. This is a study integrating multiple genomic platforms and showing that you could essentially better categorize pituitary tumors, something we've known for 100 years since Harvey Cushing started defining these, but we could better categorize these tumors based on their mutational profiles in a way that you can't do with just histology alone. And this is happening for every subtype of neuro-oncology tumor, probably in every kind of oncology disease that exists also. And this is the most recent classification of pituitary tumors, basically showing how the functional types, the types of hormones that these tumors are secreting now really is broken up into even more categories based on the transcription factors that govern their development. And these transcription factors very much resemble how normal embryology of the pituitary gland works. They divide along specific lineages, and that has an impact on kind of what the aggressiveness of these pituitary tumors are and how likely it is one's going to recur for a patient or not. The WHO, which classifies tumors for us in 2021, has essentially reclassified a lot of neuro-oncology tumors. This is one take-home message from this talk, is that molecular biology and the mutations of these tumors are really critical for diagnosis. And so when we see patients that have a high-grade glioma, we often say we can't really talk to you about prognosis and treatment options until we get the pathology, the mutational profile back. It is so important for understanding these diseases. And one of the other things that is quickly being done and more rapidly being done is the integration of newer genomic and mutational findings in management of these patients. So the C-IMPACT group basically is a group of neuro-oncologists, neuropathologists, and neurosurgeons that take findings that are coming out of the literature more quickly, putting it into guidelines to help manage patients. And so the last part of the talk I wanted to mention was about emerging technologies in neurosurgery. One of the things that's really going to be impactful for us, and then hopefully spread to other fields, is the use of augmented reality. I think augmented reality has a real role in neurosurgery because we already use a lot of image guidance in diagnosis and surgical management. I think almost more so than many other fields. And so this is a lot of work we did with a local company here called Novorad that's in American Fork. And they use a software on top of the Microsoft HoloLens 2 to help basically integrate any kind of DICOM image you have into this headset and then be able to map it onto a patient. And it's still a little bit a work in progress, but it is to a point that can be used clinically. They already have FDA clearance for preoperative planning and are shortly going to get it for intraoperative use. And it's constantly developing. There's still more developments coming out of this. So I wanted to highlight just one of the studies we did with this, which was placement of something called external ventricular drain. Basically, this is a drain that you place into the ventricles of the head for relieving pressure. Many of you may have seen this before. We tested it in various phantom models, two specific phantom models where we used different methods to measure the accuracy of the hologram system. And then we used it in a cadaver model to sort of test whether we can place the catheters into the ventricles accurately in a cadaver model. So we found with our first phantom model in augmented reality that it was highly accurate. We could get accuracy within 0.5 to 1 millimeter accuracy. So we could basically hit targets very accurately by using this system. And I'll have examples of what this kind of looks like. The second phantom kind of looked at whether we could teach residents and trainees to use this. And the take-home point from this slide is that we found no difference in accuracy amongst trainees in placing EVDs. There's no difference based on their experience with EVDs or video games at all. Basically, we took a medical student and a attending physician, had them both do EVDs, and both could hit it with the same level of accuracy, which is if you think about it, it's basically just follow the line until you hit the target, and the medical student was able to do that as well. So I think that level of accuracy has implications for how this technology could be used, not just for surgeons, but say in rural areas where you don't have surgeons, in military settings where you don't have access to not just neurosurgeons, any kind of surgeon, where you need to understand three-dimensional anatomy better. And this is kind of an example of what it looks like. These are two of our residents essentially placing frontal and occipital EVDs into the ventricle, basically showing that there was no difference in accuracy depending on their level of training. And in our cadaver model, we basically, the traditional way we place EVDs is using anatomical landmarks. So we're using the nasion, we're using the external auditory canal to identify and line up anatomy and then be able to place our catheters. Well, that gives you about an accuracy of about a centimeter. In certain situations, that will work. You get the drain into place and you help a patient. But you know, I have something going in my head. I would want it to be as accurate as possible. Even a centimeter off it can be dangerous in certain areas of the brain. What we're able to show with this study is that with using augmented reality, you can actually significantly improve the accuracy, reduce the error rate by placement. And there's some other applications for it as well. This is early work we're doing on placement for trigeminal neuralgia and getting to the foramen ovale, potentially helping with percutaneous procedures. These are various studies that we're doing looking at skull-base approaches and seeing if we can identify facial and skull-base anatomy better using augmented reality. This is a study we did with this group looking at spine. I do some spine surgery, even though I'm mostly a neuro-oncologist. The goal with this was to see if using augmented reality, you could basically place pedicle screws percutaneously or even open more accurately. And so this is an example of what this looked like. And overall, you can see post-operative images of what this ended up looking like. And using the grading system for pedicle breaches, the Gerspin-Brodmann system, you could essentially show that the vast majority, over 95% of these placements had 0 or 2 millimeters of a pedicle breach. So basically, a very accurate way to do this, and a way that could potentially be useful for settings that don't have intraoperative guidance. It could be used in community settings. So this augmented reality technology will be coming, and it's an exciting emerging field. A couple other new technologies, and then I'll be done. This is a group we're working with called Longevity. They have an implant called ClearFit. Basically, it's a cranial implant that you can essentially use ultrasound to look at the brain through this implant. Previously, one of the limitations with ultrasound is you can't pass these low frequency beams through the skull. So with this implant, this is the first example of it being used in Utah. We treated a patient basically that had hydrocephalus secondary to a core plexus papilloma that was obstructing flow. You can see preoperatively what her ventricles look like on our postoperative day. We also did an ETV procedure, which is a way to sort of internally shunt the fluids without placing a shunt catheter. That catheter there on post-op is just our temporary catheter. And basically, on post-op day 2, you can see that the ventricles have decreased in size. You can measure it. This is ultrasounding through this implant that we place. And then this is stable. You could test it on day 2. You can see that the ventricles continue to decrease to more normal sizes. This is a great technology. It could allow you to be able to non-invasively monitor patients, avoid needing scans post-operatively. You could look for changes if patients are coming into your clinic or if they're going to the ER. I'm sure many of you deal with patients that have hydrocephalus and have shunts and maybe come in with a headache. Well, there may be a time in the future that they'll have these implants that you can do ultrasound to be able to better and more quickly tell if there's a problem going on. So this is really exciting. This technology has only been out for a year, so it's brand new. It's going through clearance in our hospital so we can start using it in more patients and study it better, but it's an update. With our augmented reality system, you can integrate multimodal imaging. So you could potentially integrate ultrasound, you can integrate 4-dimensional imaging. This is cardiac-gated MRI, so you can use this as a way to localize anatomy. You can use this as a way to to teach patients. So there's a lot of applications for this work, and this is still emerging, and there's a lot to be developed from this. For the spine surgeons in the audience, anyone else putting in implants, there will be a day that you can use this technology to better and more accurately place the instrumentation in. The setup for this is also much easier than a lot of the current ways that we're using navigation and O-arm to be able to set up. There's a lot of exciting work in machine learning in our field. I know you've probably seen talks on this already as well, but certainly machine learning, this is a study we did looking at whether machine learning could be used to better classify tumors. Something as common as simple as a meningioma. By using machine learning classifier, we could help identify which ones were more aggressive, as these are all grade 1 meningiomas. We are able to classify which ones are more aggressive, and I ultimately found that peritumoral edema was a real key factor with why certain patients that have more aggressive tumors are more likely for recurrence. So this will be more often used in neurosurgery and other fields. And then another study we did looked at whether we could use machine learning to better understand our patients, better learn about which ones are likely to return to hospital. This is one looking at pituitary adenoma patients and whether we could predict which ones are going to be bounced back to the hospital. And then we validated the data looking at data from the University of Utah and Ohio State. So again, integration of technology into surgery, better understanding patients, and better sort of classifying them. So, neurosurgery is a team sport. We rely on a lot of different people to be able to do the stuff that I do, and we rely a lot on people in the community to help manage these patients. And this should be an open dialogue. It should not be kind of a one-way street at all. It really is a team effort. You can see on this slide, we have people from every different specialty working on the treatment of this patient. So these are a list of clinical trials that we're doing currently at the University of Utah. These are spearheaded by our neuro-oncologists.